Hello everyone, today we'll be talking about shoulder dystocia. So, the term shoulder dystocia is defined to describe a wide range of difficulties that are encountered in the delivery of the shoulders of the fetus. Okay, shoulder dystocia usually occurs when either the anterior, which is the most common, or rarely the posterior fetal shoulder impacts on the maternal symphysis or on the sacral promontory. Then you need to know the overall incidence is between 0.2 to 1%. So the predisposing factors for shoulder dystocia include fetal macrosomia. This is actually quite common, but what you need to know that in about 50% of cases, shoulder dystocia can also occur with normal-sized babies. Then the second predisposing factor is obesity, diabetes, mid-pelvic instrumental delivery, and it's more following ventus than forceps, post-maturity, multiparity, anencephaly, and fetal ascites. So the complications of shoulder dystocia include severe fetal and maternal complications. So fetal include birth asphyxia, brachial plexus injury, plexopathy due to the stretch, herb and Klumpke palsy, fracture of the humerus, clavicle or sternomastoid hematoma during delivery. What you need to know is that perinatal morbidity and mortality are quite high. Then maternal complications include PPH, cervical, vaginal, perineal tears, increased risk of operative delivery and morbidity. So prevention of shoulder dystocia is not accurately possible. However, you can predict it in case if a patient tells you they had shoulder dystocia in the previous pregnancy, if there is prolonged first or second stage of labor. So maneuvers that are done to prevent shoulder dystocia may be used prophylactically in cases where it is anticipated. So how do you make a diagnosis of shoulder dystocia? You notice there is a definite recoil of the head back against the perineum, which we call the turtleneck sign. Then inadequate spontaneous restitution. 3. Fetal face becoming plethoric. So when you talk about management principles of shoulder dystocia, so the first thing you need to do is call for extra help, okay? Clear the infant's mouth and nose. Do not give traction over the baby's head. And what you need to know is never to apply fundal pressure as it causes further impaction of the shoulder. Then to perform wide mediolateral episiotomy as it provides space posteriorly. I've made a separate video on episiotomy which you can check out. Then to involve the anesthetist as analgesia is ideal and the pediatrician for infant resuscitation because we just said that birth asphyxia and other complications are quite common. So management, so the following maneuvers are commonly employed, and what you need to know is there is no evidence that any one method is superior to another in releasing the impacted shoulder or reducing the chance of injury. So head and neck should be grasped and taken posteriorly while suprapubic pressure is applied by an assistant slightly towards the side of the fetal chest. Due to this, it will reduce the bisacromial diameter and rotate the anterior shoulder towards the oblique diameter. This maneuver is simple as well as effective, and it needs only one assistant. Then we've got our Macroberts maneuver, which is quite common. So in this case, you abduct the maternal thighs and sharply flex them onto her abdomen. There is rotation of symphysis pubis upwards and decrease in the angle of the pelvic inclination. This does not increase pelvic dimension, but it straightens the sacrum relative to lumbar vertebra. And this maneuver needs two assistants. And according to RCOG, they recommend this maneuver to be employed first. Then Wood's maneuver. So in this case, general anesthesia is administered. The posterior shoulder is rotated to anterior position by a corkscrew movement. This is done by inserting two fingers in the posterior vagina. Simultaneous suprapubic pressure is applied. This pushes the bisacromial diameter from the anterior posterior diameter to an oblique diameter, due to which it helps with easy entry of the bisacromial diameter into the pelvic inlet. Then extraction of the posterior arm. So in this case, the operator's hand is introduced into the vagina along the fetal posterior humerus. The arm is then swept across the chest and thereafter delivered by gentle traction. And what you need to know is that this procedure may cause fracture, clavicle or humerus or both. Then other techniques that may be used when all of the above have failed is a clidotomy. This is where one or both clavicles may be cut with scissors to reduce the shoulder girth. This is applicable to a living anencephalic baby as a first choice or in a dead fetus, okay? Then Zavanelli maneuver. So this is then where you push the fetus back to the uterus and deliver by cesarean section. Or symphysiotomy may be done rarely. So that's all about shoulder dystocia. If you like the video, please like, subscribe and comment. Thank you.